So thank you for having me on this very exciting program. I'm Surbhi Sidana. I'm an associate professor of medicine at Stanford University and lead the myeloma cell therapy program here. So today I'll talk to you all about the safety and efficacy of CAR T-cell therapy for myeloma in the context of currently FDA-approved products, and then touch upon CAR T-cells in development in myeloma, as well as practical considerations when we use CAR T-cells for the therapy of multiple myeloma. So, the immunotherapy landscape in myeloma is constantly evolving. And over the last 3-4 years, there has been so much influx and has completely changed the treatment paradigm of myeloma. We currently have two FDA products that are approved for CAR T cell therapy: ide-cel, that was first approved in March 2021, and cilta-cel in 2022. They have subsequently been approved for earlier line therapy in 2024, and that's something we'll touch upon. There's also bispecific antibodies, two against BCMA and one against GPRC5D, so teclistamab, elranatamab, and talquetamab. And they are currently approved after 4 prior lines of therapy. Let's talk about ide-cel, idacaptogene viclucel, which was the first CAR T-cell therapy approved for multiple myeloma in March 2021. Patients with heavily pretreated myeloma prior to this approval had a response rate about 30 to 40% and a PFS of 3 to 4 months. And now, in that context, comes ide-cel, and this KarMMa clinical trial was a heavily pretreated population with a median of 6 prior lines of therapy. 128 patients were treated, most of them were triple class refractory. And in this very heavily pretreated population, where the baseline response rate is somewhere in 30 to 40% range, we saw for the first time an overall response rate of 73%. A CR rate of 33%. And a quarter of these patients achieved MRD negativity, which was previously not seen. So we were very excited about this data. But this is not a cure. The median progression-free survival was about 9 months. For patients getting into a complete response was about 20 months. So we did not see a plateau as we had seen in patients with lymphoma, but this is very encouraging compared to what we had historically for this population. So then, ide-cel was tested in earlier line use in the KarMMa-3 clinical trial that has subsequently led to earlier line FDA approval. So here, patients were 2 to 4 prior lines of therapy with multiple myeloma were randomized 2:1 to getting ide-cel versus standard of care treatment, and there were 5 different options for standard of care. The primary endpoint was progression-free survival, and secondary endpoint was overall survival and different safety parameters. Important to note that crossover was allowed at the time of progression in the standard of care arm. For the primary endpoint, ide-cel resulted in a superior progression-free survival of 13 months versus 4 months in patients receiving standard of care. Response rates were also better. Now, just to remind you that there was crossover allowed, and therefore we saw some confounding in overall survival analysis. So there was no difference in the overall intention to treat overall survival, but when they did a sensitivity analysis, which was pre-specified in the protocol, adjusting for crossover, the median overall survival was superior in the ide-cel arm. There were several patients in the CAR T arm who never made it to CAR T. And you'll see this is a little bit of a similar trend seen with cilta-cel also in the future slides. But when they did an as-treated analysis, as in when patients actually make it to CAR T after the first few weeks of manufacturing, there was a trend towards overall survival benefit in the ide-cel patients. So to summarize, there was a PFS benefit and a trend towards OS benefit in the treated patients and an OS benefit when you adjust for crossover. Let's look at cilta-cel. Ciltacaptogene autoleucel, or cilta-cel, is the second BCMA-targeted FDA-approved CAR T in the US. Now, the construct is slightly different compared to ide-cel. This is camelid-derived compared to mouse-derived. It targets 2 epitopes of BCMA instead of 1 epitope, so there are some structural differences. But this was also a very heavily pretreated population with a median of 6 prior lines of therapy. Almost all patients were triple class refractory. And in this population, we saw amazing response rate of 98%, a stringent complete response rate of 83%. Two-thirds of the patients were MRD negative. Again, we were all amazed by these results. The median progression-free survival in this population is almost 3 years, so 35 months. Historically, never seen anything like this in a heavily pretreated population. So then this was investigated in earlier lines in the CARTITUDE-4 study, which I was privileged to be a part of. Here, patients with 1 to 3 prior lines of therapy who were lenalidomide refractory were randomized 1:1 to CAR T with cilta-cel or standard of care treatment with two arms, either Dara-Pom-Dex or Pom-Bortezomib-Dex as investigator choice. The primary endpoint was progression-free survival. Of note, unlike the KARMA trial, no crossover was allowed in CARTITUDE-4. And there was a significant benefit in the first readout of this trial for progression-free survival, which was not reached in the CAR T arm and was about 1 year in the standard of care arm. And the standard of care arm performed as expected. And these results were published in the New England Journal of Medicine in 2023. Last year at the IMS meeting, Dr. Mateos updated this data with overall survival results with a 34-month follow-up. The median follow-up of 34 months resulted in a superior overall survival in the cilta-cel arm compared to standard of care arm. And this is unprecedented. It's hard to see overall survival benefit in myeloma these days, and to see this much benefit, I think, really talks to the efficacy of this one-and-done therapy in multiple myeloma. And this overall survival benefit was seen across all pre-specified subgroup, whether it be 1 prior line of therapy or 2 to 3 prior lines of therapy, different risk groups based on ISS stage, extramedullary disease, or high risk. And then they compared, whether we use it in early line or late line, does it matter? So this is curves that are overlapping with the CARTITUDE-1 study. And while this is not a statistical comparison because these are two different studies, you can see that the curves for both PFS and OS for the CARTITUDE-4 study are better than what we're seeing for the CARTITUDE-1 study, suggesting that using CAR T in earlier line would lead to better efficacy outcome than using it in late line, which is not a surprise to me here. But there are some trade-offs when we talk to patients about early line CAR T. So there were more infections noted in the cilta-cel arm in the first year compared to the standard of care arm. And there are more second primary malignancies, specifically hematologic second primary malignancies noted in the cilta-cel arm at 3.4% compared to 0.5% in the standard of care arm. So these are trade-offs that we need to talk to our patients about: a better efficacy profile by far, an overall survival benefit, but some trade-offs about toxicities. So how does this all translate into the real world? The trial data are amazing, but many of us would argue that the eligibility criteria for CAR T trials can be quite stringent. And does that really match up in our clinical practice where many patients have comorbidities, many patients may not actually be trial eligible? So I have a particular interest in real world evidence generation and have been part of several studies. So let's see what happens with real world data when we use these therapies with our population who may not be as fit as the trial population. So this is real-world data for ide-cel using the CIBMTR registry of over 800 patients with a median follow-up of 1 year. This was a very heavily pretreated population, just like the KARMA trial, but 77% of these patients had significant comorbidities, many of which would have made them ineligible for the KARMA trial for ide-cel. About 18% also had prior BCMA-directed therapy, most commonly with an antibody-drug conjugate, which was not allowed in the KARMA clinical trial. So how did they fare? So when you look at the CIBMTR data and another study I was part of with the real-world evidence, despite most of the patients not meeting eligibility criteria for the KARMA trial, the safety was almost identical, and efficacy was very similar, with the overall response rate of 70 to 80% and a CR rate anywhere from 25 to 40%. And the progression-free survival was virtually identical, around 9 months. So these therapies can perform equally well in the real-world population. And we found similar data for cilta-cel. This is a study we recently published in Blood, where we looked at over 200 patients who got cilta-cel as standard of care across 15 centers. And two-thirds of these patients, again, would not have met the eligibility criteria due to comorbidities, cytopenias, prior BCMA-directed therapy of the CARTITUDE-1 trial. And yet, when we look at safety, safety is very similar in terms of cytokine release syndrome, CRS grade 3 or higher, which is what we get worried about, was low, less than 5%. Neurotoxicity was also very similar to what we see in the clinical trials. I think with cilta-cel, it's important to note there's a slightly different safety signal of delayed neurotoxicity, with most commonly cranial nerve palsy seen in about 5% of patients, Parkinsonism seen in about 2% of patients in the real world. It's seen less commonly in the earlier line setting, 0.5% in the CARTITUDE-4 study for Parkinsonism. So there's a slightly different safety signal of cilta-cel versus ide-cel. Again, non-relapse mortality was 10% in this very late population, and it's mainly driven by infections. And we'll talk about it. As these patients transition back to the referring doctor's office, I think watching for infections is very important, and infectious disease prophylaxis is very important in these patients. How about response rate in the real world? We saw that the response rates were very high, ranging from 90 to 95%, depending on different populations we look at, and the CR rate of 70 to 75%. In fact, most of these responses were quite deep. In MRD evaluable patients, 95% of patients in the real world cohort were MRD negative, which is very impressive to see in this very late line population. So, how do these two products compare? Of course, we should not be comparing across trials, yet we always do compare across trials. And so, we actually conducted a formal real world evidence analysis of the two CAR T products, ide-cel versus cilta-cel, using a very robust statistical methodology. So, we had 350 patients with ide-cel and 236 patients with cilta-cel in this population. And I will not go into the details. This is a publication that will be coming out soon in the Journal of Clinical Oncology. But we did an inverse probability of treatment weighting, which is a very robust statistical methodology to balance across different covariates. And on the right-hand side, you can see we balance for age, patient comorbidities, performance status, different disease characteristics to get a balanced cohort. And we saw some trade-offs. The PFS and OS was better for the cilta-cel cohort, but there were some trade-offs for safety. Some safety parameters were worse for the cilta-cel cohort, not shown here. So again, this data can be used for an informed treatment decision-making when we have patients in front of us when they ask for safety and efficacy trade-offs. Okay, well, a lot of the clinical trials did not allow prior BCMA-directed therapy. In fact, any of the trials that we talked about did not allow that. So how do patients with prior BCMA-directed therapy do with CAR T? So this is a publication that I was a part of that came out from a real-world consortium that showed that when you use ide-cel after prior BCMA-directed therapy, patients have inferior overall response rates and progression-free survival. And while the numbers are small, patients with prior bispecifics seem to do the worst in this population. We then looked at cilta-cel after prior BCMA-directed therapy, and about 14% of patients in our cohort had received prior BCMA-directed therapy, most commonly belamaf. And here again, we saw a statistically inferior overall response rate in patients who had received prior BCMA-directed therapy, and a statistically inferior progression-free survival. So the PFS here was only 13.6 months after prior BCMA-directed therapy, and the response rate was only 70%. But what we also saw the same with ide-cel, that the response and PFS was lower after prior BCMA-directed therapy in patients who received ide-cel in the CIBMTR registry. But the timing of prior BCMA-directed therapy might matter quite a bit. And this is a trend we are seeing in different studies as well. So in the cilta-cel cohort, about half of the patients had received prior BCMA-directed therapy within 6 months of receiving cilta-cel, and the other half had a longer interval. And what we saw was that patients who received cilta-cel within 6 months of the last BCMA-directed therapy had the worst outcomes. Their response rates were only 54% compared to 94% who had more than a 6-month interval. And the PFS was only 6 months compared to almost 17 months if you gave more than 6 months from the prior BCMA-directed therapy. So as in the community, if someone's receiving bispecific antibody or ADC, if they are going to be a candidate for CAR T in the future, I think this is very important data to keep in mind. Okay, so this was FDA-approved products. Let's look at some of the other CAR Ts in development. And there are many CAR Ts in development. But I think two that had exciting data at ASH are anito-cel and arlo-cel that I'll talk about. Anito-cel targets BCMA and arlo-cel targets GPRC5D. So GPRC5D is a target that's expressed on plasma cell. It's the same target as of talquetamab. It's also expressed in some normal cells like skin, tongue, and other tissues that respond to side effects of GPRC5D. So arlo-cel is a CAR T. This was presented by Dr. Susan Ball at the ASH meeting, and this is a very heavily pretreated population of 84 patients, out of which 26 were treated at the higher dose level. And in this very heavily pretreated population of 5 prior lines of therapy, and about half of these patients had received prior BCMA-directed therapy. So I think that's very important to note. And the response rates here were almost 90%, and the CR rates were 50%. And the response were consistent whether you had extramedullary disease, high-risk cytogenetics, and very importantly, also for prior BCMA-directed therapy. And this is the most important slide. Here, the median progression-free survival was 18 months, whether you had prior BCMA-directed therapy or not. So after failure of prior BCMA-targeted therapy, an 18-month PFS is quite remarkable. So let's talk about anito-cel. Anito-cel is a slightly different CAR T for myeloma, even though it targets BCMA, in that it has a D domain, which is a synthetically derived, smaller domain that targets BCMA. What they say is it allows more structural stability, allows more expression of the CARs on lymphocyte, but the truth is in the results. So let's see what results were reported. And here they presented a follow-up of phase 1 study of 38 patients, almost 3 years of follow-up, and the median progression-free survival was 2.5 years. That's quite remarkable. And I think what's very remarkable is that in this small patient population, they are not seeing any delayed neurotoxicity, something that is we see with cilta-cel. So the PFS appears comparable to cilta-cel, but they're not seeing any delayed neurotoxicity, but the patient population is small. They also presented data for their phase 2 study in 98 patients. Again, this was a heavily pretreated population with the 4 prior lines of therapy. And most patients were triple-class refractory, so PI, IMiD, and anti-CD38 antibody refractory. And here the follow-up is short, but the response rate looks quite amazing at 97%. And I think we are all very interested to see what happens with this CAR T construct in the future in terms of neurotoxicity. So far, no delayed neurotoxicity is seen, and whether the progression-free survival seen in the phase 1 study holds true in the phase 2 study. So then let's talk about toxicities, which are very important to manage. So the attractive part of CAR T is it's a one and done therapy that can give prolonged progression-free survival without need for any subsequent therapy. But there are some toxicities that is important to understand and manage. So here are the toxicities with CAR T in myeloma. I break them into early toxicities that happen in the first few days and weeks, delayed toxicities that happen over weeks and months, and then long-term toxicities that happen over years. So the early toxicities are cytokine release syndrome, neurotoxicity, classically ICANS or immune effector cell-associated neurotoxicity syndrome, and IECHS, which is a fancy term for hemophagocytosis, so HLH. And of course, cytopenias and infections start in the early days and can continue over the long term. Then there are some delayed toxicity. And for cilta-cel, it is important to note things like cranial nerve palsy or Parkinsonism. And they've also been reported for other CAR Ts like ide-cel, but not to the same extent. We then have some GPRC5D specific toxicities that are relating to GPRC5D expression in other tissues, so dysgeusia, expression in the tongue. We also have seen some cerebellar toxicity with ataxia and balance issue that is thought to be related to GPRC5D expression in the cerebellum. And then over the long term, second primary malignancies is important to watch. And we don't know what the very long term unknown side effects might be, as these have only been around for a few years. So I think we can talk about CRS and ICANS, but that's very similar across different CAR Ts, whether it be for lymphoma and myeloma. In fact, I would say for CRS and ICANS, myeloma CAR Ts are better and have less severe CRS and ICANS. But I really want to spend some time on the unique issues related to BCMA CAR T that can happen when patients transition back to their referring doctors in the community. So, delayed neurotoxicity. It's predominantly seen with cilta-cel, but there are case reports with ide-cel and other BCMA-targeted CAR Ts. It's not been reported with bispecifics, just to note of date. And it's a heterogeneous group. Parkinsonism, I think, is the most severe, also called MNT or motor and neurotoxicity toxicities. But cranial nerve palsies are common. Peripheral neuropathies and others can also be seen. Again, Parkinsonism is seen anywhere from 2 to 6% in the late line setting and less than 1% in the early line setting. And the median time to onset of these toxicities is about 3 to 4 weeks from the time of CAR T. Cranial nerve palsies are the most common delayed neurotoxicity with cilta-cel, seen in about 6% in the real world and in CARTITUDE trial. And very uniquely, it seems to be that the seventh nerve is involved. So it's a Bell's palsy, most commonly unilateral. The first time I saw it, I was like, is this patient having a stroke? Should I be sending them to the ED? Which I indeed did. But later we realized, no, this is not a stroke. Of course, you have to rule out a stroke. So patients should get head imaging. You need to rule out an LP if you think is clinically appropriate. But most commonly, this is just a CAR T related toxicity. And the median time to onset is about 3 weeks, although it can happen beyond the first month when the patients transition back to their CAR T centers. Sometimes it can be bilateral seventh nerve and additional cranial nerves, most commonly ocular. So the third, fourth, and sixth nerves are involved in some patients. And it does tend to resolve in most patients. It can just sometimes linger on for weeks. So, how do we treat it? I think rule out other etiologies and then treat it with low dose steroids that we taper off quickly. I also give IVIG, and many centers do that. Again, it's an almost like a CAR T immune side effect. So, giving IVIG might help there. But most patients resolve. It's just patients counseling about the time to resolution. What about Parkinsonism, right? This is a very unique toxicity. And the risk factors that have been described are if you go into CAR T with high tumor burden, if you develop high grade CRS and ICANS and get high CAR T expansion, you're more likely to get these toxicities. But why do they happen? I think we are still understanding. One potential mechanism is an on target off tumor effect. So, this is a case report that was published in Nature Medicine from the Mount Sinai group. And this is a patient on the CARTITUDE 1 trial that developed Parkinsonism 3 months after cilta-cel. And they found that this patient had CAR T persistence in blood and CSF. Unfortunately, this patient died, and then they did an autopsy and they found lymphocytic infiltrate in the basal ganglia, and the BCMA expression was seen in basal ganglia. So it's thought to be that there's BCMA expression where the Parkinson disease affects, so the basal ganglia, and the CAR Ts actually can go when they expand quite a lot to that area and cause on target but off tumor damage. Okay, how do we treat it? It doesn't seem to respond to the traditional Parkinson's medication like levodopa, carbidopa, or other medication. But there is some evidence to suggest that when you target CAR T expansion and target it quite early, and this is a case report from MGH that you targeted with chemotherapy and they use high-dose cyclophosphamide at 2 grams per meter square and steroid, they were able to reverse it. I will say that since then, we've had quite a bit of success in reversing it, especially if we catch it early and there's high CAR T-cell levels with high-dose cyclophosphamide. Now, there are trade-offs. Patients can get more infections with high-dose cyclophosphamide, which we have in our own patients. That's something to be watched for. And of course, steroids are another mainstay to decrease the CAR T expansion. What about cytopenias and infections? As I mentioned earlier in my talk, right, This is the driver for non-relapse mortality in the majority of patients after CAR T in myeloma. So why do these patients get cytopenias and infection? I mean, these are heavily pretreated patients. They have a poor existing marrow reserve. There is inflammation with T cell activation and cytokine production. And potentially with CAR T, patients have some pre-existing chip clones that may expand and cause, immunosuppression and depletion of normal B cells and plasma cells. Again, the most common infections are bacterial and respiratory viral infections. The fungal infections, the opportunistic infections, and viral reactivations like adeno, Hep B, and Hep C, we worry about can happen. We need to investigate them if we don't find common things, but they're not as common. So, common things being more common. And again, this is the slide set showing the incidence of severe cytopenias and infections with different CAR Ts in clinical trial and the real world. And again, severe cytopenias here, the messages can persist beyond 1 month after CAR T in multiple myeloma. So when patients transition back to their doctor, they might need GCSF injections for low neutrophil count. They might need sometimes TPO agonists. They might need transfusions. They might need close monitoring of blood count. So these are very important. Second, primary malignancy. I think this is something we really need to watch as data matures. And again, these patients are at risk for many different reasons. They're heavily pretreated with different therapies, including transplant and immunomodulatory drugs. There is decreased immune surveillance because of immunosuppression. Again, potential risk of expansion of chip clones. And very rarely, the risk of CAR Ts directly causing insertional mutagenesis in T cells, causing T cell lymphoma. So with ide-cel and cilta-cel, we see this. With ide-cel overall, we see 7% risk, including 1% risk of myeloid neoplasms and leukemia. With cilta-cel so far, we see a 21% risk with a 9% risk of myeloid neoplasms and leukemia in the CARTITUDE-1 study. Again, I want to caution that these differences might be due to survival bias. If patients live longer, they have more chance of developing myeloid neoplasms, and we are seeing a differential overall survival with patients in ide-cel and cilta-cel so far. So we have to take these data with that in account, but this is something we need to watch for in the future. So let me summarize what we talked about. BCMA-CAR T, targeted CAR T, is now available as standard of care for relapsed myeloma and has now actually moved to earlier line, with cilta-cel approved after 1 prior line of therapy in refractory patients and ide-cel approved after 2 prior lines of therapy. The majority of patients receiving standard of care CAR T in the US in the late line setting were found to be not trial eligible, although real world data shows that the strong efficacy and safety profile is comparable to what is seen in the clinical trials. And the efficacy really looks outstanding for this patient population. Delayed and unusual toxicities can happen, including delayed neurotoxicity and second primary malignancies, which remain an issue, and we need to be watchful. Newer CAR Ts are in development. We have many products, including targeting different antigens like GPRC5D and dual targeting CAR T. So more data to come in the coming months and years. So with that, thank you very much for your attention.